Greetings, everyone, and welcome to the Comorbidities, a journey through patient care webinar today. Please feel free to introduce yourselves in the chat and also use the Q&A box in order to ask questions. My name is Renee Edwards, and I use she, her pronouns. I'm the Director of Training and Technical Assistance at Migrant Clinicians Network. Many of you are familiar with Zoom, but we are in webinar mode today. So that means that all of your cameras and audio are turned off. We encourage participation again in the chat and Q&A box with reaction buttons and emojis to let the speakers know you're enjoying. For any other access needs, please message the hosts and panelists in chat to help you out. Slides are being shared in the chat for those who do better with following along as well. So you can open those up on your own computer if you prefer. The recording and slides will be shared in the follow-up email via Zoom within a week of today, and we'll post them on our shared website as well. Lastly, we have a transcript for the session available upon request. Next slide. Okay, this National Learning Series is sponsored by the Health Resources and Services Administration, or HRSA. This task force dives into the issues related to HIV and diabetes and chronic comorbid disease management that all impact population management and population health management. For more webinar information about the Community Health Management Task Force, visit our website, and that should be in the chat as well. Next slide. We want to briefly acknowledge the 12 National Training and Technical Assistance Partners, or NTAPs, who support this and other sessions in the series. You can read more about each one at our shared website as well. Next slide. This webinar is part 3 of the 4-part Community Health Management Task Force National Learning Series. To see the recordings, slides, and resources from other webinars, visit our shared website as well. All right, again, my name is Renee Edwards. I'm the Director of Training and Technical Assistance at Migrant Clinicians Network. I'm joined today by my colleague, Kara Skillingsteve, Associate Director of Healthcare Transformation at the Association of Asian and Pacific Islander Health Organizations, or AAPCHO. And I want to briefly acknowledge the other collaborators for the session. Jack Dalton, who's a Program Manager, and Ben Sullivan, Program Coordinator at the Division of Education and Training at Fenway Health. Next slide. Co-occurring morbidities, or comorbidities for short, present multiple intersecting challenges. Diseases often require different and at times conflicting care, instructions, and maintenance strategies. For folks who need medication, there may be drug interactions or contraindications that they need to be mindful of. Many of these challenges build off each other and are compounded further by non-medical factors of health, such as transportation, and access to food, as well as external influences such as policies and the built environment. For providers and any health center staff, it's important to acknowledge the limitations of a single clinical encounter. Most patients with multiple comorbid illnesses require frequent visits and follow-ups. If patients are experiencing multiple health challenges, it may impact their trust in the health system and reduce the likelihood that they'll reveal all of their difficulties in their first visit. It's crucial that all patient-facing staff make efforts to build trust and rapport with all their patients, but in particular, patients for whom getting to the clinic often is critical to their ongoing health maintenance. There's other factors to consider when serving patients with complex needs beyond clinical. We must be aware of potential needs to prepare for within the clinical encounter around literacy, language services, transportation barriers, caregiver support, and other non-medical factors of health, such as food, housing, insurance coverage, their income, and more. Further, we must acknowledge other potential impacts on care based on identity and life circumstances for individual subgroups. For example, language needs, continental and generational ancestry, and access to services. Next slide. It's now my pleasure to introduce our esteemed subject matter expert speaker panel. We have today Dr. Kevin Ard. He is the Medical Director of the National LGBTQIA Health Education Center at Fenway Institute and the Director of Sexual Health Clinic at Massachusetts General Hospital, where he is a practicing clinician and faculty member of the Division of Infectious Diseases. He's also an assistant professor of medicine at Harvard Medical School. Dr. Art's interests include LGBTQIA plus health and the prevention and treatment of sexually transmitted infections and HIV. We also have with us today Dr. Laszlo Madaris. He is the Chief Medical Officer at MCN. He's board-certified family physician. Dr. Madaris oversees TA related to clinical issues and clinical protocols and case review for our health network at MCN. And he's a TV clinician and professor of medicine at Penn State. Also joining today is Gabriel Piñaranda as the Program Manager of Training and Technical Assistance at AAPCHO and has years of experience working with communities around the built environment, health literacy, and non-clinical factors of health. Our panel is here for a moderated discussion where we will walk through a case study of an individual patient at the intersection of multiple comorbid illnesses and non-clinical factors that impact her care. Our speakers will try to address audience questions from the Q&A box throughout the session, but please note that we will not have time to answer all questions verbally during the discussion. Please join me in welcoming our speakers, and I will now pass it over to Dr. Madaris to share a bit more background on this topic before we transition into our case study. Dr. Madaris.
Great. Thank you very much, Renee. Welcome, everybody. It's great to have you here. Thank you for spending some time with us. I would like to start by saying one of the reasons that I became a family physician is that I could help people in the long term. What we say cradle to grave care. So I enjoy meeting my patients, getting to know them, building trust, and then working on the processes that make them sick and try to get them healthy or give preventative care so that they don't become sick. Some of the things that we're challenged with here, and we'll see a case presentation here shortly, is what do we do when there are multiple comorbidities and other challenges to a patient? Where do we start? And I want to give you a couple of examples of the risks of what happens if we don't do, what we can to prevent illnesses. I'm going to start out because I work at the TB clinic in Pennsylvania on a couple of cases in general here of what happens to patients in TB, in the world of TB at the state health department. So when I start out meeting a patient at the health center and I realize that they have latent TB, what that requires ultimately is uninterrupted prophylactic prescriptions, sometimes for only 12 weeks, but up to 9 months, to prevent latent TB to become active. Now, to do this, I have to build a trusting relationship with a patient. I have to make sure that I know, what their concerns are, their cultural background, what they understand about TB. Sometimes they come from a different country, how that country and that culture treats latent and active TB. So before I even start to talk about medications and treatment, I really have to start building a bridge with them in order to navigate through the care and to make sure that if we start latent TB treatment, that this will go on uninterrupted and that I could keep all the factors that would be a hurdle to them as clear as possible. So latent TB, I build the trust with the patient. We start medications. They see me in the office every couple of weeks, and I make sure that they're doing well with their treatment. And hopefully then this will end up with complete treatment of LTBI so that it does not progress to active TB. Other situations, we already have active TB, MTB, and that requires 6 to 18 months of uninterrupted treatment. So this requires, again, a longer investment, definitely not just a few visits. And ultimately, our goal is there to prevent patients from becoming so sick with TB that they cannot function. Untreated TB is a major killer in the world. And so it's really important for us to build a relationship with patients and get a successful treatment. In addition, some of my TB patients have HIV, and I coordinate the care then with another infectious disease doctor who will then work on the HIV side while I work on the TB side. And we have good conversations and warm handoffs back and forth so that both HIV and TB can be treated. Now, some health conditions are not only harmful for a patient themselves, but to their community. So I'm talking here about things that if we can't control TB or HIV, this becomes a harm to the community as well. Sometimes people have other burdens that they don't have transportation, they don't have access to a way to get to and from our office. And so we try to work with our social workers to make sure that they can. If we don't succeed at this, then these are infections that can cause harm to both the patient, their families, their colleagues, etc. Next slide. The other conditions are chronic diseases that affect mostly the patient themselves, such as examples here of diabetes. So as a family physician, I treat a lot of diabetes. If this is left untreated, this can lead to increase in blood glucose that affects vision, diabetic retinopathy, skin integrity, worsening heart disease, nerve damage like diabetic neuropathy, and kidney disease where patients have to go on dialysis. So prevention is the key here, and building a trusting relationship with my patients over time, in this case, over many years, because this is a chronic condition and a lifelong relationship with the primary care physician, the community health worker, the patient themselves, and often their families. Other conditions include heart disease, unmanaged high blood pressure, cholesterol, arrhythmias, heart failure, and cardiomyopathy. So all of these outcomes that we don't want to have. So prevention is the key here, and also we're working with them long term to make sure that these conditions are treatable and we get the patient as healthy as possible for a long lifespan. Next slide. So if we don't do the things that we are trained to do because of conditions that are outside of the clinic, I believe that we should go outside of our clinic and learn about our patients' community, what kind of food access they have, the challenges they have, where they live, how they live. If we don't do all this, then I think the long-term costs are much more difficult for the healthcare system, and more importantly, for me, the cost to the patient who's untreated or undertreated. So untreated can lead to harm for individual health and family well-being, harm to communities through spread of infectious disease, harm to employers through extended absences, recurrent hospitalizations. Part of my job involves being a part-time hospitalist physician at our local hospital. So when our efforts fail in the outpatient level, I often will treat these patients in the hospital and try to get them better enough to be discharged and hopefully continue care in the outpatient setting. Again, I try to employ local trusted community health workers, social workers, care managers in the hospital and in the outside clinic, because as a team, I think we can work much better to prevent harm to our patients. And then, of course, the cost of the healthcare system itself, more expensive treatments and care complications. If you don't take the TB medications you're supposed to be taking, this can lead to drug resistance, and no longer are we able to use the same medications for TB that we had when we started if the patient has interrupted care. This is very challenging in current times because people are worried about getting detained. So some people don't show up for their appointments as they used to. But we try to work through that situation as well. And we will try to avoid preventable complications of chronic diseases. In the hospital, I see patients in the ER who have been waiting for so long to get care for various reasons. The social determinants of health are very challenging. And so we try to work on that in the community outpatient level, but also in the hospital. So there's two different approaches that I use to try to develop long-term relationships and care and try to go through these social determinants of health and see if we can offer practical solutions. One of the things we do at Migrant Clinicians is to offer practical solutions. What can actually work? How can we make this work? What barriers are there that we can actually overcome so that we can get the desired results, which is a healthy patient getting their medications, getting appointments on time. Next slide. So some of the things that I really like to do is to go out into our community because I realize that if I'm in the clinic and I'm just in or in the hospital, and then I offer things to a patient, well, to avoid diabetes or to get better, let's walk 30 minutes a day. We are assuming then that sidewalks, parks are available, that this patient feels safe to go outside because they may fear arrest or detainment, or they're in a dangerous neighborhood and they fear violence. So just to say, well, let's get you walking 30 minutes a day, this might not be the best or the most possible solution. Every time we prescribe swimming, we're assuming pool access. That is a big assumption. Our community does have a Y, and I help out there sometimes to get people who can't afford membership to get them lower cost to get in. But this is also a kind of luxury that doesn't exist in many parts of the United States. And every time we say join a gym, we assume that there's some disposable income that they have for this. So we really have to understand our patient and their background before we go ahead and prescribe things that seem to be good ideas. Hey, get some more exercise. Again, I think this has already been talked about in a previous discussion, but every time we prescribe fresh fruit and vegetables, we assume a store with those items nearby, adequate income, and familiarity with preparing those items. So these are kind of things that we need to consider before we just offer something within the confines of our clinic or within the confines of the hospital before they're discharged home. Next slide. I think I'll stop there. Some of the topics I hit here, I'd be happy to discuss even further, but I think now we'll turn this over to our next speaker and then move forward here.
Thank you so much for that incredible overview and for setting the stage for this case study today. And before we jump into our discussion, we're going to walk through the journey of one patient with multiple comorbidities. Many of you know that patients with comorbidities will often have multiple visits to address their intersecting needs, as well as support for maintenance between visits. And we always know that there are multiple non-medical factors and competing priorities that may prevent our patients from even getting to the door. So today we're going to share a bit with you about some of these phases of a patient's journey, and we encourage you to share your thoughts, experiences, and questions in the chat for further discussion. So we'll start with a bit of the background, and then our subject matter expert panelists will share some insights, considerations, complications, and promising practices for each step along this patient's journey. So I'm going to pass it over to Dr. Kevin Ard to walk us through the overview of this patient who's the focus of our case study today, so we can take it to the next slide, please.
Thank you and welcome everyone. I'm an infectious disease doctor and a primary care doctor, and I'm going to share a case study that I think highlights many of the things that have been discussed and others about a patient with multiple chronic conditions and also other challenges in terms of accessing care and engaging in care. This patient is a woman in her 50s. She is living with HIV and in fact has had a diagnosis of AIDS due to a low CD4 count and opportunistic infections in the past. She has type 2 diabetes and chronic kidney disease and also high blood pressure. She has limited literacy and she does not speak or read English. And what makes communication a bit more challenging is that she has had a stroke in the past and on that basis has some baseline slurred speech. So in a clinical setting or with a phone check-in, if an interpreter is used, especially a non-in-person interpreter, often the interpreter has difficulty understanding the patient, and then that makes it difficult to have the clinical interaction as well. She is very low income. She doesn't work, and she has difficulty affording food and other basic necessities. And kind of hearkening back to the discussion that you just heard, for example, she was prescribed a blood pressure cuff to have at home so that she could be checking her blood pressure at home to help with her blood pressure management. But the particular model that she was given by the medical supply company needed batteries, and she can't afford the batteries. And so that was a barrier that she experienced with the ongoing use of that strategy. She doesn't have a car and she struggles to get to her appointments. And while there is transportation assistance available, She often has difficulty setting that up, again, because of language barriers and her baseline slurred speech. And so even though free rides to the clinic are available, that has often not fully overcome the transportation challenges that she has. Because of her multiple medical conditions, she has multiple prescriptions. And if you look at that list above, there are 5 chronic conditions there, and she's on at least 2 medications for each of those. And so this patient has more than 10 medications that she is supposed to take every day. Um, and she doesn't always take her medicines consistently because of side effects. And she also has a concern that she's simply prescribed too many medications, and taking all of these medications is is not good for her body. Periodically, she will stop all of the medications prescribed by the clinic and then see a traditional healer from her community to address her health problems. And she does mention this at times when she has clinical visits. It also may occur at other times. Sometimes the patient does bring in all of her medications to clinic visits. And when the clinician goes through these and the nurse go through these, they realize that there are some medication bottles from things that have been prescribed months or years in the past that have never been open or taken. And because she doesn't take her medication consistently, and this again harkens back to something that we already mentioned today, she's developed HIV drug resistance, and she now requires a much more complex regimen with multiple pills per day that is more difficult to adhere to. Um, and in addition, some of her other chronic medical conditions, her diabetes and her high blood pressure, are not at the goal levels. Her average blood sugar is high, and her blood pressure is often high when she comes to the clinic. This all being said, this patient does have a supportive family member who lives with her and accompanies her to care and serves as an advocate for her. And although the patient often stops medications or doesn't take them all as prescribed, she is very interested in trying to improve her health. And she actually has a fair bit of anxiety about her health and does want to make sure or hopes that many of these conditions can be addressed. So that is a brief overview of this patient, and I suspect that many of you may see things here that are that you recall or see day to day in your work at clinics around the country.
Thank you so much, Dr. Ard, for that walkthrough. And I'm excited to hear more from you and all of our panelists about this patient. So, there are several things that came up here before, during, and after the clinical outcome. So, now we're going to walk through the patient's journey, and each of you will share a bit more about some other factors to think through as we care for this patient. So, we'll take it to the next slide, and then Gabby and Dr. Vidaris, if you want to come back on camera. Okay, so Dr. Ard, let's start with you. And leading up to the clinical encounter, how would you describe some of patient-wise needs?
Yeah, that's a great question. And I think one clear need is transportation, simply making it to the clinic. And so that I think has to be one thing that we address. Um, I think, as we think about kind of prepping for this visit, I think there are other things that could be helpful too. For example, ensuring that the visit is at a time when the patient's supportive family member can come as well, because that is often helpful. Ensuring that an interpreter is available, and ideally in this particular scenario, if it's, accessible, an in-person interpreter is helpful, because of some of the communication challenges that the patient has. So, those things, transportation, ensuring a supportive person is present, ensuring that the appropriate interpreter services are available are, I think, all I think some really important things to, make sure are planned or in the works leading up to the patient's appointment.
Yeah, those are all so many different things to balance and navigate as a clinician. And I'm curious, Gabby, if there's anything that you want to share more about what may have impacted patient-wise journey to get to the clinic.
Yeah, for sure. I mean, based on a lot of these factors that were shared in her case, like her finances, her food, security, and lack of transport, I mean, those are all social risk factors for her health and her treatment. But based on these descriptions, I mean, Dr. Ard mentioned that there's a lot of anxiety. So I think what we're seeing is a lot of just stress, a lot of stress around her health, which is, of course, related to a lot of these other conditions, especially her blood pressure. But I think especially with transportation. If she relies on somebody to take her there, that's really great. But that's an additional factor that we have to consider, right? Like Dr. Ard mentioned, ensuring that the clinic is open when that person is available to take her. But even let's say, for example, if like she wanted to take public transit, and given her limited literacy, we would also wonder what her digital literacy is. So if she's relying on paper bus timetables or paper schedules or routes, are those in a format that is legible or comprehensible to her? And that's just for transportation. So if we wanted to, if she wanted to take the transportation that was provided by the clinic, we would ask the same question, like, is that something that she has to register or sign up for online, which might be challenging for her. I think another concern that I'm thinking of is if she's not working, finding a job is probably going to be really on top of mind for her, especially since in this like our healthcare system, healthcare is so intricately tied to our work. So that's going to be one of her immediate concerns potentially and adding to her stress. So I think what we're seeing in this patient is just a lot of stress, but mental time thinking about a lot of these things that are related to her basic needs that aren't even her healthcare.
Totally. And thanks for bringing in the perspective of just how she might be feeling. We've talked a lot about how the clinic can prepare for this patient and also some of the mental preparations the patient might need to make. So, Dr. Madars, anything we missed? What may have been helpful to know before patient Y arrived that could improve her visit?
Yeah, I think first of all, Dr. Arndt, this is a very, very challenging patient. I give you full credit here for, it's a very difficult situation to navigate so many multiple conflicting needs, but all piling into this patient's health. One thing I try to do is to understand the language and the culture that this patient is coming from. And we already mentioned having, if at all possible, in-person interpreters there who I think in person, given the stroke and the speech difficulties that she may be having, in person is much easier than telephone in my experience. But I try to build on like what is the culture where they're coming from, and having worked in other countries, what I've often tried to do is to get the trusted leaders in that community, church leaders, community health workers, even the curanderas and the traditional healers. Actually, I would actually try to get in touch with to see how we can maybe work together or enlist them as allies rather than confrontational if possible. This is always a challenge because we're trained in allopathic medicine and a certain way of doing things, and sometimes those are not complementary, but often surprisingly they can be. And so where there's common ground, I would like to enlist in the help of the trusted leaders of the community that I'm working in. And a lot of times in other countries, I'm the stranger and I have to adjust to what the local situation is and understand people's background and their fears. And in that regard, I think bring in the trusted leaders as much as possible. It's great to have this family member who's available. In my hospital here, I sometimes ask for a health aide or a nurse potentially who speaks either Haitian Creole or Spanish, or ideally, some language that the patient can relate to and culturally is similar. So those are the kind of things that I would add to this as to how to perhaps build some more rapport with the patient, and as they come into your office, how best to be prepared. I often find that my front desk, they've been really good now, but the front desk is your first approach. And even if you're a great physician, as Dr. Arndt would be, by the time they get to the physician, they've already had several experiences from the front desk and the nurse, et cetera. And just to make sure that your whole team, the front desk, how they're received in the building, makes them reassured that they're welcome and that our concern is their well-being.
Absolutely. And thank you so much for bringing in the idea of these trusted leaders, trusted community messengers to help us sort of build a relationship and foundation of trust with our patients. And I'm curious if you did talk about this a bit, Dr. Madaris, about building rapport with our patient. I'm wondering if there's anything else you would think about as a clinician or a provider to build rapport.
Yeah, so again, I think using words that people can understand, very basic, and I use a teach back method sometimes to see, okay, so what did you learn from what I just said? What are you going to do? What are our plans? And I think there's another question I might be jumping ahead, but she may have some concerns here, and I would like to have her tell me what her priorities are as well. In that, if I can meet her halfway in what her top concern is, maybe we can get down to the second and the third and the fourth. But I mean, it's really challenging here because there's so many different conflicting challenges health-wise. But I'd like to ask her, what her priorities would be and what would make it helpful. So I can see sometimes I work with the patient to lower their hemoglobin A1C and their blood pressure. Those are things that I can show them in the office sometimes, like, hey, we did this, and this comes. This is working better. HIV and resistance is it's more challenging. It's certainly much more dangerous to leave this HIV untreated, but there's certain things that I like to prioritize if it's consistent with what the patient wants. I can win on a couple of levels here and then show them, hey, you took these medications and this is working. So these are some of the challenges and some of the things I try to do in my office to move ahead.
Awesome. Thank you so much. And thanks for that global answer to almost all of the questions on this slide. So I'm going to turn it back to Dr. Ard to share a bit more about, as a provider, as a clinician, how do you build rapport with your patients, or specifically, how would you with this patient?
Yeah, so I think similarly to what Dr. Medeiros said, when I begin the visit, I often say something like, there are a couple things I want to make sure we discuss today, but tell me what are your biggest concerns today? What can we most do to help you today, to try to understand what they think is most important and to address those things as well in the visit. And then I think one thing that gets at a couple of these points, rapport, preparation for the visit, and that is time. This is not going to be a 15-minute visit or a 20-minute visit. And so if you have that flexibility in your practice to be able to schedule a patient like this for a longer period of time, I think that can be enormously helpful, because then you are able to spend a lot of time listening and understanding and building a connection with them. And I think that it probably saves time in the long run, in the sense that it helps build rapport. But I think that can be another key aspect of care for this patient or other patients.
Thank you, Dr. Ard. And then, Gabby, is there anything additional, aside from what Doctors Ard and Madaris have already shared, that you think would support building rapport with this patient?
Yeah, I mean, I love this question. So, yes, ideally, she's working with somebody who speaks her language, like right off the bat, like entering the clinic. We've seen examples from our health centers where there are signs when they walk into the waiting room, and it says, like, if this is your language, you go directly to them. So, what that means is somebody who maybe doesn't speak English or has this feeling that they're going to go to the clinic and no one's going to speak their language. As soon as they walk in, they see a sign in their language that tells them this person can help you. I love that as an example. I think something else to think about too is eye contact. It's important for sure, but in some cultures, like sustained or direct eye contact could be rude or disrespectful. So kind of knowing that balance, like Dr. Medeiros said, like starting from that idea of understanding their background, and what they think about is important for relationships or building relationships. So additionally, like you already mentioned, there's opportunities for other ways to ensure that there's like mutual understanding, like the teach back method. Um, and I also think, just like Dr. Ard mentioned, time is a big one. But what I would emphasize is time to just chat. Time to chat, time to yap. I know, Carrie, you know that I love to talk, and that's what's been really effective in building relationships, at least for me, with CHC staff and community members, is not starting from like this place of business. I know it's important. I know that like provider and staff time is really, it can be really limited, but like 1 to 2 minutes, just like asking, how's your day? What have you done today? Like knowing that they're there for this reason, like, yes, they're at the clinic, but like recognizing that they had all of these other stuff that they had to do today. And the fact that like, yeah, they want to take care of their health, but they're taking the time to be with you. I think starting off from warmth and kindness and just like recognizing each other as people first is going to be really important.
Thank you so much for that perspective. And this comes back to what you shared, as well as what both Doctors Ard and Dr. Medeiros shared, which is that this is a real person. We want to meet them where they're at, and we want to use a patient-centered lens. So before we wrap up this first initial visit, any of you, is there anything that we missed? Any other considerations that we should be mindful of when serving patient Y?
One other thing I just want to mention is that, again, I mentioned the meeting the front desk first, reinforcing the message there, then meeting the nurse, getting the vitals, and the nurse enforces the message also, so that by the time I get them, they've already had 10 or 15 minutes with my staff, and we all have the same message, and we all have an embracing method of working with them. And so my 15 minutes or 20 minutes gets added to theirs, and so it becomes a little bit longer of an experience for them sometimes. So I can try to make that work, but I understand in primary care how challenging it is to have these shortened visits and lots of patients coming through the office. And sometimes we forget that, we need to take that time. But I'm lucky and I have a great staff. And so the additional work that the nurse does, the community health worker maybe have brought them in. We have people going out to the community to give rides to people to come in. So they're reinforcing the message. Everybody's reinforcing the message. So it may appear to them that they have longer than just the 15 minutes they have with the clinician himself or herself. So sometimes that's an additional plus if we have great staff working.
One thing I'd also just throw in is, I think as a clinician, it's also important to realize, we're not going to address all of the medical issues at this visit. I think we need to, in collaboration with the patient, pick a few to focus on, and agree with them that we'll address some things, next time and the times after that, because, there's so many things that are going on, and I don't think we can do a good job with all of them, all at this one time.
Absolutely. All right. Well, thank you so much to all of you for sharing your insights around that first visit. So that kind of wraps up this initial visit, but let's see what happens next. If you can take us to the next slide, Ben. And we all know that care needs don't stop when the patient leaves the clinic. And there's a lot of different ways that patients have to process and retain and then act on the information that is shared during the clinical encounter. So let's walk through some of the ways this might get derailed for patient Y. And Dr. Ard, I'm going to start with you. What are some considerations for patient education?
Great. So, one is that we wanted to make sure that that any materials the patient was given, and in fact, even their prescriptions and so forth, were actually in the language that they speak and read. And so we were able to work with the pharmacy and ensure that that could happen. And I think another really crucial aspect of education for this patient is also, again, kind of engaging this very supportive family member who the patient wants to be involved in their care, to kind of also, be present with the education, to also understand what the counseling is that's provided, because that, I think, can also be really helpful between the visits. And I would say that, this may go a little bit into the next bullet, but one thing that can sometimes come up is, challenges at the pharmacy. So at the visit, we agree with the patient, we're going to, start this medicine or simplify this and send that to the pharmacy. And then the patient goes to the pharmacy and, a prior authorization is needed, or the medicine isn't ready, or there's some other barrier, and then things can kind of fall apart. And so, trying to ensure that we establish kind of good communication back and forth, and, even having check-ins from the nursing staff or community health worker or other clinic staff a few days after the visit to see, how things are panning out with the plan that was put into place can be really helpful.
Thank you, Dr. Ard. And Dr. Medeiros, anything else? Any other
Yes, yeah.
considerations?
I'm
Yeah.
gonna do a shameless plug for MCN. So we at MCN have education material also written in local languages, mostly Spanish and other languages. But we have a comic book series on kidney disease, on worker safety, pesticides, heat exposure, HIV, diabetes. We have an excellent one on diabetes as well. It's written in a general Spanish that our whole team worked together. We have people working from Puerto Rico and Colombia and Venezuela and Mexico to put together a kind of a general Spanish uh, comic book that can tell patients, here are things that you can do in a way that's very understandable. And I know she doesn't read herself, but it seems like her family member hopefully does. And so, what I would recommend in a situation like this is that if you have some of these in the office, take a look at them yourself, make sure that they're appropriate to what you want to teach them. But we've had these comic books out for several years now, and we keep developing newer ones to meet the needs of our Migrant Clinicians Network patients. And I think Renee can share some of the access to those because you tell somebody something and some of it sticks, but if you have a comic book that is actually very easy on the eyes as well. We have great artists at MCN too, so it's a great team of people working on this. So this is another piece that can be useful for people who need this information. I've taken some of these comic books with me working in Honduras, and people just loved it. There's all sorts of information there that whatever I say is, for the 10 minutes that I'm with them, but they take the comic book home, they come back with questions later on, and it really sinks in a little bit more. So it's one of the things that I feel like, is helpful education wise. So we really enjoy that. So anyway, it's just a little plug for MCN's material there.
We love a shameless plug, and I see that Renee already popped a link to some of your resources into the chat, and we will make sure to share those in the slides as well as the follow-up email through Zoom. So thanks, Dr. Badaris, for that. And then, Gabby, you kind of shared a little bit earlier about some considerations for patient education, like health literacy, tech literacy, and just general comprehension. So could you maybe walk us through some examples of other competing priorities that might interfere with the follow-up and care instructions from the provider?
Yeah, I mean, I think here something that could interfere is overwhelming them from like a non-clinical perspective or from the clinic staff perspective. I think a lot of health centers have a lot of really wonderful resources. So yeah, I already mentioned like health literacy, but I think one of the key things here is to be strategic with how we're approaching their care journey. So like Dr. Ard mentioned, it's going to take a lot of visits. So not starting off from a place where they feel like not overwhelmed and feeling like what they're doing next is really manageable, is going to be really important here. So maybe like continuing off this like literacy perspective, maybe the clinic staff can start from there and say, okay, well, if literacy is a concern here, that's going to have lots of other repercussions. Do they have or do they know of literacy programs that they can refer the patient to? So I think being strategic and taking some of these things into account can alleviate or mitigate some stress. And I think another point that was related to the previous question about like time is when it comes to patients and everybody who's like a patient-facing staff. I know that you've talked to dozens, and I'm sorry if that's like a gross understatement and you've talked to hundreds, but like I know you've talked to dozens of patients already. But as a patient, their interaction with you is one out of like a handful. So that's going to have like a little bit of a greater impact. So I think remembering that when you're sharing these resources and everything that you're doing as a staff member, they're going to have such a great interaction with them is going to have such an impact. So remembering that like they haven't heard some of the resources that you've shared, even though you've shared it dozens of times that day. So I think remembering that is a good place to start.
Thank you so much for that, Gabby. That's a great reminder to all of us, myself included. And then Dr. Medeiros, do you have any other competing priorities or ways that the health center can support this patient to address these priorities that you'd like to share that we missed?
I mean, I think many of the competing priorities that have already come up are pertinent to the between visit time as well. Concerns about food security, income, transportation to future visits. All those things I think are relevant here. And then one other thing I would say, just and it I think pertains more to the patient education bullet point. And this is true for many people with multiple chronic conditions, but many of these conditions are asymptomatic. people don't necessarily feel if their blood pressure is a little bit high. They don't feel if their blood sugar is a little bit high. They don't, feel anything about chronic kidney disease. And, HIV is, of course, asymptomatic for a long time as well, too. And so, um, you know, we can't necessarily make the person feel better with the treatments that we are prescribing and recommending. And so I do think that often involves a lot of education and working with patients to express why we think it's important to address these things, answering their questions about that and using a teach back method, as Dr. Medeiros mentioned, because for many the kind of urgency or need to treat many of these things may not be apparent, and of course, if they have side effects from the medicine, we kind of made them feel worse than they did before.
Totally agree. And I think I can understand how you all would approach patients with humility and with centering autonomy. I think it's just also really important to not build shame. And so to use a motivational interviewing approach to understand people's and patients' why as well. But Dr. Menares, I saw you unmute.
Yeah, I just wanted to echo what Dr. Arndt said too, because that really resonates with me in my TB clinic. Latent TB infection, you don't feel sick, and yet I give you medications that can, turn your urine a strange color or make your sweat look funny. And so I'm causing new problems that they didn't have. And so how do you sustain that relationship and that trust over 4 months when you're making the patient maybe a little nauseous, a little tired? Some of these medications can take a toll on you, and it's building that trusting relationship to get them through that couple of months that they're being treated. So I completely agree that they're not feeling bad at first, and now they're taking these medications, and I see that in the hospital too. I bring down somebody's blood sugar from 300 down to 100, and they're feeling terrible. And I'm saying, no, this is good. This is, but they don't feel great because their sugars are way lower than they used to be. So it is a really challenging issue, and I think building that trust, and this is why, again, primary care or building a long-term relationship with your patients are so important because they learn to trust you, and that this is yeah. Anyway, I completely agree with Dr. Arndt that this is a challenging thing to get them to take medications when they're not feeling bad just as the way they are.
Totally. And, creating a relationship with our patients is a great segue actually to our next slide. And I appreciate you all so much for those insights. So let's shift back to the clinic. Let's go to the follow-up visit. And you've all already mentioned multiple times that with complex patients, it may take multiple visits to address their co-occurring needs. So for this scenario, we'd like our audience to imagine that patient Y has, against all odds, made it back to the clinic and they're here for their follow-up visit. And then we're going to walk through some of the scenarios and thoughts. So, Dr. Medeiros, I'd like to start with you. How might the provider or the health center staff prep in advance of patient Y's visit?
Yeah, so if they know that this patient is returning, again, a warm welcome. Welcome back. It's so nice to see you. We saw you a couple months ago. I hope you're feeling better. Make them feel like they're known. They're a known entity right there at the very beginning, the first person that meets them at the door. And then the nurse, saying something there. I will often put little stickers into the chart that doesn't go into the official chart. They have a dog named Fido or something like, how is the dog doing, and what's going on here? Just little things that may mean a lot, and they're just easy to touch base on. But I won't remember necessarily unless I write little notes sometimes. But little things may help make them feel a little bit more welcome. And so I think that's one thing. And as Dr. Arndt mentioned, having an interpreter potentially there, in person, so that they can understand whatever the dysarthria or whatever's happening after this stroke, the residual neurological disorders after the stroke can be potentially overcome face to face a little bit easier than they can be over the telephone. So I think those are great ideas. And then also understanding that they may feel a little shame if they didn't get to do all the things that you would ask them to do. And so I think starting off right away, finding the positives of what you were able to do and say, hey, that's great. You did this thing with your blood pressure or whatever it is that, make sure that it worked. Also, I want to make sure that when they come in, they'll also be able to feel comfortable enough to be honest with me and say, I couldn't afford that other medication. I'm sorry. And this is something I've dealt with a lot in all sorts of circumstances where, my cardiologist friend prescribed a great medicine, the best medicine, but they can't afford it. So I got to take that medicine away, and I'll give the next best one, which is actually affordable, which they actually can use. And so sometimes, I will work that out before they come back to see me to make sure that they can afford the medications. But I can anticipate the question of, what actually are you able to take, during this visit. But that might be the next bullet point here. So sorry, I went ahead.
No, that's okay. We love it. I'm gonna ask Gabby to take us back for a second, but what are some other non-clinical preparations that the health center could make to share with patient Y or prep to see patient Y?
I think Dr. Medeiros touched on two of the ones that I specifically mentioned. So I like the post-it note in their record to bring back some of these things that they mentioned, just to show that they were listening and uh, continue that conversation. So like if I had emphasized that a way to build rapport is to have a chat and have a conversation, and it's part of this healthcare journey, then what that means is that you got to continue the conversation at this follow-up visit. And then also giving signals within this follow-up visit to show that, okay, at your next visit, this and this, like it's not just like a one and then a two, because like Dr. Medeiros mentioned, there's probably a little bit of shame there, or is some existing anxiety, but showing that no, we're in it for the long run. We're in it together, and we're in it for this journey. And definitely encouraging staff before this patient comes to uplift their agency and decision to come back. So yes, you already knew about a lot of these external factors that were or presented barriers to their care. But it's so important to emphasize that the patient had power in their healthcare journey to come back, to go to the doctor in the first place, but to come back, and that's going to really set the stage for all of the follow-up visits.
All right, thanks, Gabby. And Dr. Art, anything we haven't talked about yet that we could do to prepare for this follow-up visit?
So this is maybe a bit of a twist on your question, but I think sometimes I've certainly had the experience where somebody comes back to a follow-up visit, and we learn that the medicine I prescribed at the last visit, they had a side effect and they stopped it after a couple of days. And so I think making sure people know how to reach out in between visits with questions or concerns, because often those are things we could address over the phone or in between these visits and kind of make right and help people. And so ensuring that patients, including patients who don't speak English, for example, know how to reach us, know how to contact us. For example, in our setting, they first would call the interpreter line that we have at our hospital, and then that line calls the clinic. And so ensuring people know how to do that is really crucial. I also just want to emphasize what's already been said about ensuring that we kind of ask things in a way that does not convey judgment or shame if the patient did nothing that we suggested at the last visit, but they really approach it with curiosity and kind of understand, tell me why that didn't work, or what would work better for you, things like that.
Awesome. Thank you so much. And, I'm looking at the time and I have a lot more questions that I want to ask, but you've all sort of been answering all of the questions on this slide throughout this discussion. So I'm wondering if there's anything we missed that you'd like to share. One final, 1 minute thought about how we can support this patient around any feelings she might be having or any issues she might be having, any assets we want to uplift. What are we missing? Gabby, I'm going to start with you.
Uh, yeah, I mean, I think there have been so many good examples of being champions for patients, like regardless of where you are at this clinic or at a health center, wherever they are in starting or restarting their journey. So I think among them, two things, at least from my perspective, are of paramount importance. And one of that is like if your staff or you as a provider are being champions for them, that's wonderful. But I think leaving them with this feeling that they have to be actually first and foremost their own champion for themselves. So just like Dr. Ard mentioned, feeling like they can say that I didn't take this, or maybe I don't understand this, so I reached out. I think building that is also really important. And then also recognizing that they come from a certain background and that their health as an individual is often reflective of their health as a community. So remembering that that they are an individual and that they have very specific needs as an individual, but also that they are so deeply connected to the communities that they care from, so that we should recognize potentially if there are recognize and remember all of these complex needs that they have as a member of a certain community, and any like disproportionate harm, and just yeah, starting from that place.
Thanks, Gabby. Dr. Medeiros, do you want to take us away with
Yeah,
your final
so
thoughts?
I think the one thing missing right here, and I think one of the on the chat here, I noticed somebody asking about depression screening. I think that's really important to talk about as well, because obviously with all these comorbidities, there may be additional things to discuss there, and to at least recognize it, acknowledge it, and say, hey, this is actually a normal human response to everything that's going on in your life. So not making it feel like, okay, there's another illness that we have to treat, but more like, hey, these are human responses, and we can maybe help in some ways here. And then again, also, I know Dr. Arndt works very hard, and all the clinicians work very hard. And at Migrant Network, we have another program called Witness to Witness that we put together during the COVID pandemic, when there was a lot of stress on patients and providers and all the community. My nurses working in the state health department working on TB as well as COVID. So making sure that our providers are also cared for, and this may be like one patient out of 15 that Dr. Arndt has to see that day, and so it is a challenge for that too. So I just want to touch base and honor that possibility that our providers are also needing some kind of consideration. So I just want to put that out there as well.
Thank you for reminding us that workforce needs are just as important as patient needs to create that healthful environment. Thank you so much. And Dr. Ard, any final thoughts you'd like to share before we close out?
Just one final thought is I think it's often helpful to, take a step back with the patient too and say, tell me what is most important for you. What goals do you have? And I think that really helps you understand their perspective. And then often those are goals that you can align with them on, and help them achieve as they relate to their health.
Wonderful. Well, thank you all so much for your remarkable insights and support of our audience today. And audience, please give a round of applause to our incredible speakers for sharing their time, their insights, and their expertise with us. And thank you all, speakers and attendees, for all you do to support health centers and our communities. I wish we had 2 more hours to hear from all of you. But we'll move forward to the next slide. And we do have some resources available. We don't have time to walk through them today, but these will be available in the slide deck that's shared in the follow-up email via Zoom and on the shared task force website within about a week. We can go to the next slide. Here's some references from the didactic portion of the session, which you can review in the slides later. Next slide. And we hope you'll join us for the final session in the National Learning Series, Leveraging Technology to Enhance the Patient Experience, which is hosted by the National Healthcare for the Homeless Council, Health Outreach Partners, the National Nurse-Led Care Consortium, and MHP Salud. And all of today's attendees were automatically registered for that webinar, but if you'd like to share this opportunity with others, please use the registration link in the chat. Next slide. And we have shared a link to the evaluation in the chat, but when you exit the Zoom, it will automatically pop up in a separate screen. So please do take a few minutes today to complete the evaluation. It helps us keep our trainings free, and it also helps us improve future programs. And if you don't have time to complete it today, we will be including the link to it in the follow-up email along with the slides and recording within about a week. And I wanted to see if Renee, our other facilitator, had anything else to share before I completely close this out.
Thanks for squeezing me in, Kara. Yeah, just for our participants who don't happen to normally provide HIV care, something that I have found in the past really helps patients maybe think of it differently. I think a lot of people in the world are still, if that's not their field of work, are living in the 90s with HIV and don't understand all the amazing things that are available now, and helping them understand the concept of undetectable equals untransmittable. So if their patient understands that if they take their medicine, they can get an undetectable viral load and not transmit HIV to potential partners, it really, I think, frees up their mind to think, okay, maybe they were thinking, I'll never have a partner again, no one's going to want me, or they think this is a death sentence, and it's not, right? It's not the 1990s anymore. So often knowing that this is a possibility for them still, I have seen has helped people want to take their medication so they can get there and start to feel normal again in that sense.
Wonderful. Well, thanks, Renee. And that brings us to the top of the hour. I wish we had more time to go through all of the questions in the chat, but our thank you to our heartfelt thank you to our funder, HRSA. And then thanks again so much to our speakers and our attendees for joining us today and for sharing your time and just for all the invaluable work you do to support the community. Thanks so much for being here and take good care.
Thank you. Bye-bye.